بنقدم أستاذ دكتورة رشا طريف. طبعا الدكتورة رشا eminent endocrinologist عين شمس، جامعة عين شمس. هتتكلم على الفيتو ماتيرنال اندوكراين لينك. أرجو إن الناس تكون يعني تستفيد إن شاء الله، والحضور نقدر نقول ايه، الهايبوجلايسيميا ما تكونش اثرت عليهم رغم ان احنا هنتكلم على اندوكراين. اتفضل.
انا بقلب بده. تمام. تمام. ادي بقى ربنا يسهل كده والناس تبقى. بسم الله الرحمن الرحيم. بشكر الدكتور محمد على الفيري كايند انترودكشن. بشكر دكتور محسن، دكتور احمد بدر، دكتور عبله على دعوتي اني اكون موجوده معاكم النهارده، ودي اول مره ليا في دمياط. مبسوطه جدا بوجودي مع حضراتكم، سعيده يعني. يا رب اقدر في ظل الهايبوجلايسيميا اللي احنا فيها كلنا يعني اوصل معلومه تكون مفيده. هتكلم عن الماتيرنو فيتال اندوكراين لينك. is it transient or for life؟ واللينك دي اقصد بيها ان when the mother has a maternal endocrinopathy how will it affect the fetus and the neonate later on. The first question, is there a link between the maternal and the fetal endocrine system? Of course, the answer is a very big yes, indeed. There is a link, direct link between the maternal and the fetal endocrine system simply through the placenta. And I think that this is a real challenge. It's not easy, just because when managing maternal-fetal endocrinopathy, every step counts. If this is the physician, the mother and her baby are following the physician. So the endocrinologist and the obstetrician should be very careful when dealing with these cases, because the problem that if not properly controlled, the maternal-fetal endocrinopathy, as if we are throwing the mother and her baby from up down to hell. So it's a very important thing to deal with. Physiology of pregnancy alters the course of most endocrine glands, and screening for common endocrine disorders during pregnancy is extremely important, because maternal endocrinopathies have a profound impact on the fetus and the neonate, as I will show you right now in the cases. So simply, endocrine disorders in pregnancy cause fetal and neonatal endocrinopathies. The most common, of course, is gestational diabetes, and the second common is thyroid disorders with pregnancy, and then we have parathyroid, pituitary, adrenal, and ovarian endocrinopathies, which are less common. So let me tell you some maternal neonatal endocrinal stories. Of course, the first and the most common is gestational diabetes. Diabetes in pregnancy is either pre-existing diabetes, either type 1 or type 2 diabetes, or gestational diabetes which develops during pregnancy, which either resolves after delivery or continues as permanent diabetes. So, regarding the updated ADA guidelines proposed in 2015, we screen the pregnant females at 24 to 28 weeks using oral glucose tolerance test when the fasting cutoff is more than 92 milligrams per DL, the 1 hour more than 180 milligrams per DL, and the 2 hour is at 153 milligrams per DL. Normally, during pregnancy, there is a balance between the stress due to placental hormones and the compensatory increase in the insulin secretion, which occurs during pregnancy. And if this balance is impaired, gestational diabetes will occur. So it's an immune inflammatory response which occurs during pregnancy. We have placental hormones like growth hormone, cortisol, prolactin, and we have inflammation, inadequate stress response, glucolipotoxicity causing insulin resistance, ending up by diabetes. So how does gestational diabetes occur? We have insulin resistance, we have obesity sometimes occurring with pregnancy, we have an immune inflammatory response ending up by gestational diabetes. So we start by insulin resistance and then relative insulin deficiency ending by a total deficiency necessitating insulin therapy during pregnancy. And the effects of gestational diabetes vary according to which period the baby was exposed to hyperglycemia. If it's early in life, before 9 weeks gestation, malformations are common, and this is a very important point. Before 20 weeks, fetal islet cells are incapable of responding to hyperglycemia causing IUGR. And after 20 weeks, and this is very popular, the fetus responds by hyperinsulinemia, B-cell hyperplasia, and will present with hypoglycemia. And of course, there's a very long list of consequences occurring with gestational diabetes, either maternal, fetal, or neonatal. And this is our point. Maternal diabetes increases the incidence of abortion and stillbirth. It causes impaired fetal growth, fetal anomalies. It decreases the parathyroid maturation, causing hypocalcemia and hypomagnesemia, decreases the lung maturation, causing RDS, relative hypoxia, polycythemia, prolonged neonatal jaundice, and of course, importantly, we have the B-cell hyperplasia, hyperinsulinism, causing severe hypoglycemia in those babies with fetal macrosomia. The babies are born large and they are more exposed to birth traumas. So we have a lot of metabolic anomalies and other abnormalities occurring in the babies. It's not only that, we have long-term consequences of gestational diabetes later on in life. Anatomical malformations, hypothalamic dysfunction, obesity, neurocognitive and neuropsychiatric disorders occurring in these babies later in life. So let me start by showing you this case. This is Ali. He's a one-day-old infant with gestational diabetes. Her A1C was very high, 10.2, all through the pregnancy. She is on insulin, long and ultra-short acting. The baby developed generalized tonic-clonic convulsions, lethargy, poor feeding, cyanosis during feeding, and the baby was born at 36 weeks. His birth weight was large, 4.7. He was admitted in the neonatal ICU for RDS and convulsions. The family history, the maternal grandpa had type 2 diabetes as well, and the parents were non-consanguineous. If you look at the baby here, he was born very large for gestational age, puffy, plethoric, jaundiced, tachycardic, tachypnic, respiratory distress, cold extremities, hypotonia, and lethargy. And regarding suggested investigations and monitoring in this infant, during labor, maternal blood glucose should be kept at 120 milligrams per DL, Apgar score, resuscitation if needed. It's very important to feed the infant every 2 to 3 hours, maintain the thermal temperature, and very important to monitor the blood sugar at the first hour and then every hour for the next 6 to 8 hours at hour 12, 24, 36, and 48, because they are very liable to hypoglycemia, as we said. We also should monitor the hematocrit at hour 1 and 24, bilirubin if jaundice appears, and of course calcium and magnesium if the baby is jittery like our case. Let me show you Ali's investigations. Hemoglobin was high and the hematocrit, polycythemia. The random blood sugar was very low, hypoglycemia. Magnesium was low, calcium was low, phosphorus was high, and the parathyroid hormone was very low, as you see here. So the baby developed functional hypoparathyroidism. And also there was indirect hyperbilirubinemia here. What else would you like to do in this baby? Remember, the baby had cyanotic attacks while feeding. Would you like to do any investigation additional? Yes. First, we went systematic. There was cardiomegaly and pulmonary congestion on the X-ray. And here, as you said, the baby had VSD. So he has congenital anomalies, not only metabolic abnormalities. And when we did an ultrasound, he had absent right kidney. So let me ask you, at which trimester do you expect this baby to be exposed to hyperglycemia? Yes, first trimester onwards, because as we said, when the hyperglycemia of the mother starts early in the first trimester, anomalies are common like this baby. So that's very good. And regarding the management, we manage the hypoglycemia, IV glucose 10%, 2 cc per kg, and then infusion at a rate of 5 to 8 milligrams per kg per minute. And then you check the blood sugar after 30 minutes and hourly. When stable, taper the infusion rate. If not, you increase the infusion rate up to 15 milligrams per kg per minute according to the degree of hypoglycemia. And of course, further metabolic errors should be corrected, like hypocalcemia, IV calcium gluconate 10% slowly, hypomagnesemia by magnesium sulfate, treat RDS if needed, polycythemia, and phototherapy or exchange transfusion if needed in such a baby. So it's a really not easy case to deal with. And then we have the maternal thyroid disorders. There are some physiological changes which occur during pregnancy, and there is estrogen-mediated increase in the thyroid binding globulin, which causes an increase in the total T3 and T4, but physiologically, the free T3 and T4 are not much altered in pregnancy. And then we have the HCG stimulation of the TSH receptor. So physiologically, in pregnancy, there's serum TSH concentrations appropriately reduced. And the thyroid antibodies which could develop during pregnancies are either anti-thyroid antibodies, what we call the anti-thyroperoxidase or thyroglobulin, and these are associated with postpartum thyroiditis or hyperthyroidism. And we have the TSH receptor antibodies, either the stimulating type causing Graves' disease or the blocking type causing hypothyroidism. And so the TSH receptor antibodies during pregnancy, what we call the TRAB, is either stimulating antibodies, thyroid stimulating immunoglobulins, the mother will develop Graves' disease during pregnancy, or blocking antibodies, thyrotropin binding inhibitory antibodies, the mother will develop Hashimoto's thyroiditis. So it's according to the type of antibody, the mother could either develop Graves' disease with the stimulatory type or hypothyroidism with the inhibitory or the blocking type. So when the mother has Graves' disease in pregnancy, we have one of two scenarios. If the mother is not adequately treated, she still has high T3 and T4, low TSH, high stimulatory antibodies. She is still thyrotoxic. The stimulatory antibodies will cross the placenta to the baby, causing fetal TSH receptor stimulation, fetal thyrotoxicosis, ending up by neonatal thyrotoxicosis, which could stay till the age of 4 months. The other scenario, if the mother is overtreated, she becomes a hypothyroid, low T4 and T3 with a high TSH. This causes suppression of the fetal thyroid gland, fetal hypothyroidism, and neonatal hypothyroidism. So please remember that if the mother has got Graves' disease, the baby could be either thyrotoxic or hypothyroid according to the status of the mother. Of course, the best is to make the mother an euthyroid so that the baby is born with normal thyroid functions. And let me show you this case. This is the story of Ziad. He's a 1-week-old infant. His mother had uncontrolled Graves' disease during pregnancy. The baby was born restless, irritable. The mom was pre-eclamptic and the baby was born very small, 800 grams, 28 weeks, severely tachycardic to the degree of heart failure, hyperthermic, goitrous, exophthalmic as you see here, and craniosynostosis. So regarding the investigations, what would you like to do for the mom and the baby? Of course, looks like thyroid disease, and these were the thyroid functions of the mother. Look at here, we have a high T3, a high T4, a low TSH, and the stimulating antibodies are very high. So the mom has got Graves' disease. What about the baby? Here, the mom has got Graves' disease and she's not properly controlled. So what do you expect the baby to be? Yes, very good, thyrotoxic. So the baby, as well as his mother, had a high T3, a high T4, a low TSH, and the antibody was high. So here we have a case of neonatal thyrotoxicosis secondary to maternal Graves' disease. And the management here is the anti-thyroid drugs. We either give the propyl thyrouracil in the first trimester or methimazole. And please take this very important information. Both drugs are completely safe during breastfeeding because we are always asked, shall the mother breastfeed? Yes, don't stop. The mother could breastfeed her baby safely as long as the doses did not exceed 150 milligrams for the propylthyracil and 15 milligrams for the methimazole. And then we repeat the thyroid functions every 2 to 4 weeks. And it's important to follow up the liver functions and the CBC for fear of agranulocytosis and affection of the liver function. We also give beta blockers sometimes if the medical treatment fails or if there is a contraindication or side effect, there is the subtotal thyroidectomy. Another important piece of information is radioactive iodine is contraindicated during pregnancy because it causes fetal thyroid ablation, and breastfeeding should be stopped 4 months after ablation. So this is dangerous, radioactive iodine, but regarding the medication, it's completely safe. And then we have management of the neonate. It's very important to maintain the temperature, fluid and caloric intake, beta blockers, treatment of heart failure, anti-thyroid drugs, completely safe even in the neonate, 1 drop per day of Lugol's iodine in the first few days. So this was the first thyroid part, the thyrotoxicosis, and then we have maternal hypothyroidism. Of course, a lot of risks pose maternal hypothyroidism. We have abortion, hypertension, anemia, preterm labor, postpartum hemorrhage. And reflected on the fetus, we have preterm birth, fetal and perinatal death, low IQ, respiratory distress, and of course, the cretinism, which is a very big problem. And let me show you the case of Yara. She's a 1-month-old infant. Her mother had uncontrolled Hashimoto's thyroiditis. She had hypothyroidism with pregnancy. And she was on L-thyroxine, but she was not properly controlled. And a very important thing is that the baby skipped the neonatal screening program. The baby had lethargy, poor feeding, perinatal history was uneventful. The baby was born a little bit short, 48 centimeters, bradycardic, hypothermic, pale, and prolonged neonatal jaundice, which did not respond to the usual lines of therapy. As you see in this photo, the baby was puffy, coarse, with umbilical hernia. And please remember that neonatal screening program is very important for congenital hypothyroidism, which is simply measuring TSH by a heel prick on a filter paper. And of course, we all know this program is established in Egypt since the year 2000, and it's related to the birth certificate. So it's very difficult to skip the program, except if the parents are not interested in making the certificate soon. And that's why cretins are no longer seen nowadays. This is not a child, by the way. She's a 20-year-old lady, but she looks very ugly, short, and mentally retarded. Of course, this is the cretinism, the untreated hypothyroidism, and the picture is in black and white, as you see, because thanks God we don't see cretins anymore. And now let's go back to our case. Suggested investigations, a mother with hypothyroidism. Of course, we should do thyroid functions for the mother. The mother had low T3, low T4, high TSH, and anti-thyroglobulin blocking antibodies positive. So the mother has maternal Hashimoto's thyroiditis, uncontrolled hypothyroidism. And then in the baby, what do you expect? The mother has uncontrolled hypothyroidism, blocking antibodies. What do you expect for the baby? Yes, neonatal hypothyroidism, again low T3 and T4, high TSH, and a high antibody titer. So we are facing a case of neonatal hypothyroidism secondary to maternal Hashimoto's thyroiditis. Of course, the management is sodium L-thyroxine immediately after the diagnosis. Please don't wait. In that baby, the baby was living in a rural area and the neonatal screening was not very well established, so it's very important to start the treatment. For the mother, we start 50 to 100 micrograms a day according to the severity, and for the neonate 10 to 15 micrograms a day. Again, Eltroxin is safe with breastfeeding. It's normal for the mother, if she's taking Eltroxin, to breastfeed her infant. What we need is, whatever the mom is thyrotoxic or hypothyroid, is to maintain her in an euthyroid state and to take her medication and to take a safe pregnancy and safe breastfeeding with the medications. And then we have the maternal parathyroid disorders. We all know that the parathyroid normalizes the serum calcium when it goes low, either by promoting resorption of the bone or increasing renal tubular reabsorption of calcium and increasing the phosphorus excretion, or increasing the intestinal absorption of calcium and phosphorus through the active form of vitamin D. So the net result of the parathyroid action is high calcium and low phosphorus. During pregnancy, fetal calcium requirements are 300 milligrams a day, and what physiologically happens during pregnancy is increased renal loss of calcium, no significant effect on the parathyroid hormone, and higher vitamin D levels in the last trimester. And the maternal-fetal parathyroid link is very easy. It's the reverse. We say fetal parathyroid status is the reverse of the mother. If the mother has hyperparathyroidism during pregnancy, the baby will have hypoparathyroidism. And if the mother has hypopara, the fetal neonatal system will be hyperparathyroidism. So it's just the reverse of his mom. Maternal hyperpara occurs commonly due to parathyroid adenoma. There's a high incidence of stillbirth and preterm labor, and the mom will develop postpartum hypercalcemic crisis, hyperemesis, stones, generalized weakness, and please remember, importantly, the baby will have hypocalcemia. And the pathophysiology is when the mom has hyperparathyroidism, there's a chronic intrauterine exposure to hypercalcemia, causing suppression of the fetal parathyroid, transient hypopara in the baby, so the baby is the reverse of his mom, hypocalcemia in the newborn. And let me show you Jana's case. She's a 2-week-old infant. Her mother was diagnosed as hyperparathyroidism with a known parathyroid adenoma. She developed recurrent tonic convulsions with upward gaze, generalized carpopedal spasm and generalized tetany, lethargy, poor feeding, laryngospasm, an attack of apnea and cyanosis. Her perinatal history and systemic examination were completely normal. And the suggested investigations is the panel for the parathyroid hormone action. The serum calcium in the mother was high. The serum phosphorus was low. Alkaline phosphatase normal. Parathyroid hormone is high, and the rest of the panel was okay. So what does the mom have? High calcium? Yes. Maternal hyperparathyroidism. So what do you expect the neonate to have? Yes, excellent. The neonate has hypopara, the reverse of his mom. Low calcium, high phosphorus, and a very low suppressed parathyroid hormone. So we have a neonatal hypopara secondary to maternal hyperparathyroidism. And here, elective neck exploration is tolerated in the 3rd trimester. It's allowed, no problem. And oral phosphate and treatment of hypercalcemia in the mom is very important by IV saline, furosemide, calcitonin, or bisphosphonate. For the baby, it's very important to give immediate IV calcium gluconate because the calcium reaches very low levels in those neonates, 0.5 to 1 cc per kg, up to 6 milli per kg per dose, of course, very slowly. And it's better recommended to give the IV infusion because when you give the IV shot, sometimes the calcium is lost in urine. And please remember this tip. You must always start vitamin D in addition to IV calcium. If you keep giving IV calcium all through our life, it will not rise adequately except when you add vitamin D. And the dose is 0.25 to 0.5 micrograms a day. And then you monitor calcium and phosphorus. And once the baby is asymptomatic, shift to oral therapy of vitamin D and calcium. And sometimes we add phosphate chelators. The second topic of the parathyroid is maternal hypoparathyroidism, either autoimmune or post-thyroidectomy. The mother will develop facial and muscle spasms, cramps, paresthesias, spasms, and convulsion. And the pathophysiology is exactly the reverse of what we said. When the mother has hypoparathyroidism, there's chronic intrauterine exposure to hypocalcemia. So there is hyperplasia of the fetal parathyroid, transient neonatal hyperpara, and the reverse will occur, hypercalcemia in the newborn, which is transient and persists till the age of 6 to 7 months. And this is the story of Saif. He's a 3-week-old infant. His mother was diagnosed even before pregnancy as having APCAD, autoimmune polyendocrinopathy type 1. And part of this autoimmune polyendocrinopathy is hypoparathyroidism, mucocutaneous candidiasis, as you see her nails, and there is vitiligo as well. So this is autoimmune polyendocrinopathy. The baby developed lethargy, poor feeding, vomiting, polyuria, bradycardia. His perinatal history and systemic examination were normal. And let's look at the investigations of the mom. The calcium is low, the phosphorus is high, and the parathyroid is low. So what does the mom have? Yes, maternal hypoparathyroidism. What do you expect the baby to have? Yes, excellent. The baby has neonatal hyperparathyroidism, high calcium, low phosphorus, and a high parathyroid hormone. So this is neonatal hyperparathyroidism, secondary to maternal hypoparathyroidism, exactly the reverse. So for the mother, we give very large doses of vitamin D, calcium, low phosphate diet, and sometimes phosphate chelators. For the baby, proper hydration is very important. This is the most important thing. Furosemide, calcitonin, bisphosphonates. Sometimes we give steroids to lower the calcium level, and in severe cases, dialysis could be needed. The third important part of the parathyroid disorder during pregnancy is pregnancy-associated osteoporosis or osteomalacia, which is very common in Egypt. It's extremely common. Nearly 100% of the mothers. It's either due to increased calcium demands during pregnancy or poor intake of calcium and vitamin D, causing a reduce in the bone mineral density of the mother. And we started to have a new term, congenital rickets, in the newborn. In the past, we used to say we have infantile rickets. It starts at the age of 6 months, but now we see rickets in the neonates, what we call congenital rickets, due to severe osteomalacia in the mother. The mother experiences back pain, hip pain, fatigue, weight bearing, and exposure to the sun, vitamin D and calcium, of course, are extremely important. And because an ounce of prevention is worth a pound of cure, it's very important to remember supplementing maternal pregnant females with vitamin D, and the adequate dose is 600 international units a day of vitamin D, in addition to calcium and vitamin D, exposure to the sun, and only 10 to 15 minutes of moderate sun exposure of hands, arms, and face 2 to 3 times a week without sunscreen is sufficient. We don't need to stay in the sun the whole day. It's only 10 to 15 minutes. And please remember that vitamin D should be supplemented in infants from day 1. It's no longer like before. It's no longer at 2 months or 3 months. Day 1, regardless the mode of feeding, breastfed, artificially fed, we must start vitamin D. And these are the suggested doses of vitamin D intake proposed by the Journal of Clinical Endocrinology and Metabolism, updated in 2016. And this is the dietary calcium intake, again proposed in 2016 by the Journal of Clinical Endocrinology and Metabolism, from day 1 until adulthood. And let me show you the case of Mariam. Mariam is a 2-month-old baby, infant. Her mother had osteomalacia during pregnancy. She was very negligent. She did not take any calcium or vitamin D during pregnancy. The baby developed tetany, generalized tonic convulsions, lethargy, poor feeding, attack of apnea and cyanosis, and she had craniotabes, as you see in the photo. It's very clear, and bowing in her lower limbs. Suggested investigations revealed, as you see here, low calcium in the mother, low phosphorus, and the alkaline phosphatase is very high, and the parathyroid is high, and this is secondary hyperparathyroidism due to hypocalcemia. And vitamin D is insufficient, as you see here. So the mother has osteomalacia, as we said. What about the baby? What do you expect the baby to have? Yes, congenital rickets, congenital neonatal rickets, exactly like his mom. A low calcium, low phosphorus, very high alkaline phosphatase, sky high, 1,143. And secondary hyperparathyroidism with very low vitamin D, even lower than his mother, because he doesn't have any stores to take from. So our diagnosis is neonatal congenital rickets, secondary to maternal osteomalacia. So please think of congenital rickets. It's not rare, it's very common. And these are the x-rays of the baby. As you see, broadening, cupping, and fraying. Again here, these are the same findings. And it was so severe to the degree of right radial mid-shaft fracture, in addition to marked osteopenia of the bones, as you see here. And again, same findings with rickety rosaries. And the management, let me show you the updated doses proposed by the Endocrine Society Practice Guidelines 2016. And these are the doses from day 1 until adulthood. Again, we start vitamin D from the first day of life. This is very important. And let me show you the result here. This is 6 months after treatment. A healing line started to appear, and the baby is doing fine. And then we have the maternal adrenal disorders. Please remember, they are very rare. We don't see them a lot during pregnancy. And the most important part here is virilization of a female fetus due to affection of the mother. It's either due to maternal intake of progestins with androgenic actions. In the past, there were some hormonal therapies containing androgens which caused virilization in the moms, or it could be due to androgenic ovarian tumor secreting androgen, or adrenal tumor secreting androgen. So we have virilizing maternal ovarian masses. And this is the last case. This is Zainab. Look at her mother. Zainab is 1 month-old infant. Her mother developed hirsutism and virilization during pregnancy. The mother was completely normal before pregnancy, but she started to have coarseness of her voice, hair in her face, virilization. There was no history of drug intake. She didn't take anything. And the baby was born with ambiguous genitalia. She's a female, she's virilized. There is no hyperpigmentation, no salt losing symptoms, normal blood pressure. And this tells you this is not adrenal, because everything is normal, and the perinatal history was normal. And when you're facing a virilized newborn, the cornerstone is karyotype and ultrasound. This is step number 1. There is a lot of investigations and dilemmas to do, but this is the basic, karyotype and ultrasound. And then you have a panel of lab tests: sodium, potassium, aldosterone, cortisol, ACTH. Don't forget 17-hydroxyprogesterone to rule out congenital adrenal hyperplasia, testosterone, adrenal androgens, and sometimes genetic studies for mutations. And these were the lab tests of the mother and her baby. The only finding that we had is a high total and free testosterone in both the baby and the mother. And all the other panel was completely normal. And we confirmed the karyotype of the neonate. She was a 46XX neonate. She's a female. This means that she was exposed to something producing testosterone during pregnancy. What would you like to do for the mother to confirm if she has something producing testosterone? Would you like to search for something in this mother? Yes, tumor, yes. And this is what we found. Pelvic ultrasound of the mother showed a mass in the ovary developed during pregnancy with multiple cystic lesions, what we call luteoma of pregnancy. And this is a tumor which occurs only during pregnancy. It's a hyperplastic reaction. It produces testosterone. And what's important in this tumor, it causes virilization of both the mother and the fetus, both of them. Think of luteoma if both of them are virilized. And the only finding, as we saw, is high testosterone in both of them, and everything is normal. Luteoma of pregnancy regresses spontaneously by the end of pregnancy, but if it's causing marked virilization, the only way will be surgery, and then surgical correction of ambiguous genitalia of the baby, and the baby will not need any further treatment because she is normal. She was only affected by her mother's tumor. So, after showing you a lot of maternal endocrinopathies and how adversely they affect their neonates and their fetuses, let me tell you the conclusion here. Physiology of pregnancy alters the course of most endocrinal glands. Screening for common endocrine disorders during pregnancy is very important. Screening for neonatal endocrinopathies is essential. If you find maternal endocrinopathies, don't wait for the manifestations. If you have an infant of diabetic mother, look at the blood sugar of the neonate. If you have a mother with hypopara, look at the calcium and phosphorus of the neonate. Don't wait for them to manifest. Maternal endocrinopathies have a profound impact on the fetus and the neonate. And fortunately, most of neonatal endocrinopathies, secondary to maternal endocrinal disorders, are transient. Most of them go by the age of 6 months and they don't persist. Some of the ways are straight and smooth and nice, like this way. And sometimes it's very complicated and interconnected this way. And this is the case with maternal-fetal endocrinopathies. I tried to simplify as much as I can, but it's really not that easy. It's very difficult. We are dealing with a mother and a baby, and we need to cross the bridge with them both safe and sound. And this is really, really difficult. But I think that the state of the art is early diagnosis and proper management of maternal endocrinopathies to help to reduce the risk of fetal and neonatal complications, to avoid the vicious circle of the maternal-fetal endocrinal link, which could be really dangerous. We could lose the baby and sometimes the mother as well. And this is the bad side of the maternal-fetal endocrine link, the vicious circle, if we don't manage it properly. But I think we can take the happy part of the maternal-fetal endocrine link when we follow the physiology and try to normalize the functions, the endocrinal functions of the mother and her neonate. In such a case, I think we will take the happy part of the maternal-fetal endocrinal link to see the happy faces of the mothers and their neonates, like a lot of mothers and neonates. And thank you very much for your attention.
شركة مونو ميديا ترجو لكم دوام المناسبات السعيدة.